as healthcare continues to evolve and advance at the pace at which it's advancing, keeping up with emerging technologies, keeping up with disruptive innovation, I'll call it, is challenging. I think we have to defer to the individuals on the front lines, to the surgeons, to the clerks who are scheduling people, to see and recognize they're the ones best positioned to solve challenges because they see them every single day.
So the Innovators Network is needed sort of in the grand scheme to help people really build that energy and enthusiasm and that grit. We embrace the wild ideas and the potentially unthinkable.
We very firmly believe that the best solutions for veterans are going to come from VHA employees who have the problems in their face every day. We also really tailor their training and the programming to empower employees, to give them new tools and build this little innovation army that then takes those tools back and keeps using them throughout their career.
The role of an innovation specialist is to work with frontline employees to identify, test, and potentially spread innovative practices, products and practices throughout the VA. What's great about Spark Seed Spread is that I find it's a way to get your ideas heard, to test them, and to be a part of the future of VA.
I think that the ones that are the most interesting are the ones that seem to be creating something from thin air. A nurse from Boston can just see a problem and be like, I don't have the right blood pressure cuff for this veteran. It doesn't exist. And she's like, I'm gonna make one. That's exactly what she did. And she created a prototype, and now she's gonna test it.
The space that we play in is not the same as meeting your performance metrics and doing everything better, faster, cheaper. We're looking at building out and closing that possibility gap.
We define our success in the number of lives saved and changed, which means that if I have one innovation that solved a problem for one veteran, that one life changed is success.
Okay, welcome back, everybody. Hope you're all having a great day. Thanks for sticking with us. I hope you've enjoyed all the content thus far today and over the last couple of days. Welcome to the session 1 of the VHA Innovation Experience demos. My name's Frank Zitko. I am the Technical Innovation Specialist for the VA Northeast Ohio Healthcare System in the Cleveland, Ohio area. And I am thrilled to be here to introduce all of our wonderful presenters and panelists here today. So for the demos in this session, they'll center around delivering better healthcare to our veterans in a nutshell. So these presentations, represent a diverse array of practices from VA employees on the front lines who deliver excellent care to our veterans day in and day out. So as a reminder to our presenters, you'll each have 3 minutes to present, and then we'll allow 3 minutes of Q&A. So please be mindful of that so we can stay on track of time. So just to introduce our panel quickly, we have Bryn Cole with us from the Innovators Network. She is the Director of Programming for the Innovators Network. We also have Indra Sandal, who is an Innovation Specialist from Memphis, Tennessee, and the entrepreneur in residence for the ecosystem at large. And finally, we have Catherine Beckner, the Innovation Specialist from Hunter Homes VA in Richmond, Virginia. So without further ado, I'd like to get started. These first few presenters, you'll notice a common theme with regards to the COVID-19 Maker Challenge, hosted by, of course, Challenge America, who you've heard from the past couple of days. So I think these are all problems that we can all appreciate and all relate to regardless of our background. So I encourage you to sit back, relax, and enjoy. So batting leadoff, we have Hunter Futo, who's going to tell us about her open source N95 respirator and Virtual Fit AR mobile app. Hunter, welcome.
Thank you, Frank. I'm really excited to be here today because my project is for the healthcare workers out there that are helping everybody else. Y'all need innovative solutions too. My name is Hunter, and I'm an artist and engineer for emerging technology. This is my electric church. Once upon a time, I was in school for fashion design, but it wasn't right for me, so I switched to STEM instead. Many years later, those disparate paths finally converged when I set out to redesign the N95 respirator. I'm familiar with PPE. I wear it in my shop sometimes. Most of it doesn't fit. I know it's designed for men. Wearing it is a subtle and persistent reminder that my safety and comfort are secondary to profit margins. Nearly 80% of healthcare workers are women, and they're wearing ill-fitting equipment up to 12 hours a day. The message isn't so subtle for them. I was on the GAP's website the other day. Did you know they offer jeans for men and women in 88 different sizes? That doesn't even include cuts, just sizes. Most N95s come in two, large and small based on European male proportions. If respirators don't fit, they're not 95% effective. The first version of my mask was folded from Tyvek like origami and was designed to be disposable. The second version is sewn like jeans from a waterproof ballistic nylon used in military gear. It accepts an N95 filter and the holder locks it into place. Then I challenged myself to create a third version that could be 3D printable and manufactured more quickly. I didn't know how to model that myself, so instead I took the 2D flat pattern and imported it into a fashion CAD program with a physics engine, and eureka, this generated a 3D model in seconds. And this is the printed version of what you just saw. The straps are made from medical wrap, and soft neoprene gaskets form an airtight seal that does not fog glasses. The other half of this project is an AR app. QuickFit uses the depth camera on your smartphone to measure your face and determine your mask size. Then you can virtually try on the device to visually check for fit. And you can customize it like a pair of sneakers, changing the mask color, and grill design. What if we stopped scaring patients with Darth Vader masks and wore pandas on our faces instead? Once I got this working, I thought to myself, what if I took this further? If the app could capture specific data, such as the length of your nose or the shape of your chin, it could choose from an array of lots of patterns. I don't know, maybe 88 of them. This would be a scalable solution for a custom fit, and the measurement data from multiple users could be used to evolve the patterns over time. I'd like to continue my momentum on this project, but I cannot pedal alone. I need the insights of experts and testing to find the flaws in my design. In addition to your feedback, I'm looking for co-conspirators that want to help me bring, that believe in me and my mission, and want to help me bring this product from my lab into the market and onto the beautiful faces of our healthcare heroes. And the app is a whole nother endeavor. It's not just for masks, but for any PPE worn on the head. Who knows, maybe I could even take the technology that I've developed to design a perfect pair of jeans. Thank you.
Thanks, Hunter. You know, I must say I'd probably get a Cleveland Browns one now that I can
yes,
say that. I've seen the Saints jerseys. Let's
I am taking requests.
Yeah, let's take it over to our panel for questions.
Got to find that mute button. I just have to say, Hunter, well done. That was an excellent pitch. From the Innovators Network side, I have to say that it's been really a pleasure to work with you and to help you refine all these things. I would love to hear a little bit more about what made you get involved in the COVID-19 Maker Challenge, and tell us a little bit about who you are as a person and how you came to be involved in this project.
I had given up on inventing, and I had scheduled a technical interview. I was going to get a software job at Google or something. So then the pandemic hit and the lockdowns in LA started. And I saw on my Instagram, I have a lot of maker friends and a lot of hacker friends, and they were 3D printing masks and showing them. I'm like, that's really cool. I also have asthma, and I needed something that was ultra protective. So the 3D printed mask didn't fit me very well. So I decided to make my own. This is gonna sound weird. I put a bra on my face. That's how it got started, and it worked. And so I'm like, if I were to design a bra, how would I do this? I came up with darts and things, and made a mask, and just started researching it in general. And then through the NIH 3D Print Exchange, I had signed up for emails from them, and I think America Makes sent me an email about Challenge America. So I signed up for that and got a great team. And I really want to thank them, because they helped me take a project that was just in its very, very early stages, and help me refine it and have an actual user to talk to and interview with and respond with, and have a team to give feedback. And so I want to thank Team Happy Face, and especially Brian Patterson, for some of those conversations. The Panda Face and the kind of fun stuff with the app came directly from that.
Thank you so much, Hunter, for your such an amazing pitch. I have a question regarding your reusable mask. So tell us a little bit more that how often you have to change, how much it will cost if you have to change your gasket and the other stuff which is reusable.
I mean, there's a couple different versions. The Cordura version, I imagine it's something that could be placed in an autoclave or something that's washed. It would definitely be washed after every use. I'm not sure if this is necessarily appropriate for clinical use, though. I think this is something that would require a lot of testing. Definitely see it for active jobs and people that are out on the field. With LA and the fires that were happening, this was really nice to have around. The 3D printed version, the straps, again, just medical wrap, so it's something you already have around, and it works really nice. It's very grippy. The mask itself should be thrown away after each use, and the neoprene gaskets too. So everything gets thrown away, filter gets thrown away, but the mask itself can be sterilized and reused.
Okay, thank you.
Great. Well, thanks a lot, Hunter. Great work, and continue the great work that you're doing. We're going to stay with the COVID Maker Challenge theme and turn it over to Kevin Patel. He's going to talk to us about the tessellation sanitation station. Kevin? Kevin?
Yeah, hi. Sorry about that. My name is Kevin Patel, affectionately known as Team HermTech now. Hermes was a god of innovation, and tech comes from speed. So we ended up building PPE in March like everyone else. The world shut down, didn't know what to do. We were just a bunch of makers and friends from around Dallas that wanted to help. We quickly realized that our 3D printers were taking like 40 minutes and the lasers were like taking 2 minutes to make shields. So we tried to get it down to like 4 seconds, retooled in like 2 days, got it down to about like 2-something seconds per shield, make about 5,000 a day. Like 3 or 4 people, volunteers. And that's how we kind of met. We started donating them to the Dallas VA, to the ICU, COVID, ER units, because we were making ones that were autoclavable and reusable and didn't have foam for infectious disease. And that's kind of how we ended up here. One of the nurses, Thune, invited us to this Challenge America Maker Challenge over the weekend. Said, hey, it'll be fun, it'll be a weekend thing. And now we're here like 6 months later. They didn't tell us that part about how long anyways. So during it, we couldn't get $200 of funding to build PPE sanitation stuff because the shields wouldn't fit the mask and gloves. We were assigned to make stuff for the the cleaning staff with all the stuff coming in and out. So instead of taking 5 minutes for a UVC cycle, we made it like 10 seconds, and we put 432 watts in it instead of 6 watts like normal. So we literally we're like, hey, let's cram 100 times the power in it and make it 100 times or 50 times quicker. And that's what we came up with. We tested with help of the Dallas Biolab. This week, the Minneapolis Adaptive Design and Engineering program came out with 2 of the version 2s that are gonna go out to Caitlin, super VR nurse, you'll see later on here. And this thing's pretty noticeable. So as we're taking around the Dallas VA, I'm pretty sure a lot of people noticed it. Dr. Clancy noticed it, that was cool. The first question they have in the ERs are like, oh my God, you mean we can quickly clean awkward, large things in like 10 seconds? They want to stick IV stands in there. They want to stick the pumps. They want to stick the wheelchairs. So the trick about this is all the panels are the same shape. So you can make it 3 times taller, wider. You could switch out sanitation technologies. So right now, this is all UVC, but you can have a heat panel and a mist panel and whichever other combined technologies. It's very modular. So I have no more time. Thank you, 100 people that helped.
Thanks, Kevin. That's great. I think there's a great example of, VA partnering with industry and academic affiliates. That's one of the best parts of the Maker Challenges. So great work. Let's take it over to our panelists for any questions they might have.
Well, Kevin, great job. And thank you so much for you and your Maker community for coming together and making those donations at such a time of need. We appreciate people like you and all over the country. I'm just curious, in those 10 seconds being so much more powerful than the typical machine, does it produce much heat, and how hot does it get? And also, do you think, how big do you think this thing can get? I know you said it can be almost any size. I'm curious what you see as the next iteration.
So it doesn't really get hot, and it definitely doesn't get Texas hot. So that's a good thing. It really depends how much electricity your wall outlets can take. Like at some point we build it so big, it goes over 15 amps. So we could probably stack about 3 of these together. Then we got to start cutting down on the power of the bulbs. But the next iteration, I see us as like, we need to do some testing. We don't have a meter, and that's why we're here with the VA. There's no other place that can invest in things like this, because they have a clean mission to help people, and it's not really the economics or different things. It's really academic oriented and playful, and just like, hey, let's try it out. Let's see if it helps. So I see us getting a UVC meter, doing some more swab testing besides swapping my flip-flops and trying to kill COVID that way. So I see them moving into the ER, frequently used items that are hard to clean. And, so after VR, I'm just rambling now. So yeah, do you have another question?
I do, Kevin. First, oh, sorry, Indra. I want to say.
Go ahead.
Great. That was one of your best. That was awesome. Quick question. You mentioned that now you're refining with Minneapolis. There's a nurse, a VR nurse named Caitlin. I know that she's in Asheville. You're doing stuff in Texas. How are you meeting all of these people within the VA?
I guess people just we just build things, and somehow it's just all came together. I think COVID was a great connector and Zoom, So, I mean, we build stuff quickly. HermTech comes from innovation and speed. We actually just build and make the MVPs within a week. And I think that raises some questions. We do another project like every week, every month, just knock it out, right? I think we have 4 or 5 stuff going on with the VA now.
Great work. Great work. We're out of time, but thanks for the presentation. Let's again stay with the theme, the COVID-19 Maker Challenge, and go to Hazel Mann. She's here to talk to us about Volant.
Thanks, Frank. Hi, everyone. My name is Hazel. I'm with Volant, and we're saving workforce lives from COVID using affordable AI-powered biosensors. So this all started because I had a friend, John, and he was really stuck between a rock and a hard place for a recuperative care nonprofit working for low-income patients that were recovering from COVID. And they were really overwhelmed with the costs and resources needed to stay compliant with all the new regulations. His employees were working in fear of being infected, and visitors had to go through really tense screening experience every time they entered the property. So basically everyone was struggling and no one was happy. So my team of PhDs and AI scientists decided to take a privacy first approach to what we found was a $10 billion opportunity in a massively underserved enterprise market to prevent the spread of COVID with a more comprehensive platform that acts like a smoke alarm for infection systems. So unlike other expensive solutions that are just out of reach for your average business owner, we wanted to make an affordable and privacy-first system that avoided facial recognition and location tracking, and to give real-time alerts on symptom risk. So our modular system is made up of 4 main components. So we hacked cheap thermal camera cores and increased accuracy with AI by over 99%. And so this is an example of one of the camera cores. These are our prototypes that we've done so far. And then these are the wearables that we're importing from the EU. So these are FDA EU approved. The wearables track pulse oxidation, heart rate, and core body temperature on a clinical level. And then we have a mobile-based symptom checker that grades risk based on personalized baseline using machine learning in order to coordinate schedules for backups if they get sick. So the way it works is usually users really simply talk to an AI chatbot that looks like this, and it's really easy to fill out. It only takes 40 seconds to do every day. And then once they submit it, they get scored and cleared and issued a pass for work. So they take this QR code and then they go to the kiosk at work and it scans their temperature, and it can tell whether they're wearing PPE or not and log their temperature to that count. It can also tell if they're not wearing PPE and log that to the analytics as well. So we've developed this AI in the last 4 months and we've had significant traction. We launched 2 pilots, one of them with one of the advisors from our competition for symptom check with the VA. So that was really great. Right now our AI is within FDA requirements. We're reaching FDA accuracy in less than 2 months. And we secured 2 contracts to import the clinical grade wearables from manufacturers in the EU. So our secret sauce is we have a patent pending AI system that reduces hardware costs while protecting privacy. So we pass on those savings to our customers. And in the next year, we're developing deep tech AI for asymptomatic infection screenings, all via mobile. So we have a B2B SaaS model, and we're selling all the hardware at or close to cost and primarily monetizing through the software. And our plan is to make the system immediately available to frontlines and high-risk populations like long-term care. And we plan to release to essential workplaces next and expand to schools early next year. So now is a perfect time for us to launch. There's no HIPAA compliance needed. We don't need FDA approval since we're doing screening, it's not diagnostics. And we're raising $3 million to fund the engineering hardware and looking for customers and partners to help us gather and train our AI for asymptomatic infections. Thank you.
Great job, Hazel. So that's staying on the preventative innovations theme that's been often discussed here this week. All right, let's turn it over to our panel for some questions.
Thank you, Hazel. It was really nice presentation. I think so. I also remember seeing your presentation in the Innovator Network when you presented there. But tell us a little bit about how different is your product, what is available in the market, or is it the aggregation of all different products which is available in the market?
Yeah, so really great question. So we have a really modular approach to this. So we consider ourselves a data company, not a hardware company. So really actually hardware agnostic is the AI that we train comprehensively end to end on the entire system. So the problem with most systems today is they only offer one piece of the puzzle, either the mobile part or the wearable part or the kiosk part, and all that data never talks to each other. So you have a really fragmented view of risk in your organization. Because my background is in data science and property technology, making all those things talk together is really important in order to identify risk as early as possible. And so our AI is trained and off of what's considered personalized baseline stats for every individual. So for example, most things will discriminate against people with dark skin or females, because if you're pregnant, postmenopausal, your temperature is going to be very different and you'll always red flag. Also, if you're darker skin, Apple Watch, Fitbit, they use a technology that doesn't read well with people with darker skin. And so these things are not taken into consideration. Facial recognition is used on thermal cameras, and that discriminates, and it's proven against people with darker skin as well. So our whole system is made to be neutral and high accuracy, and in order to protect that privacy and have the best read of risk possible for each organization.
Thank you, Hazel.
Thanks, Indra.
So Hazel, I'm curious, it sounds like you have a lot ahead of you. So what are the next steps for your solution?
Yeah, so for our next steps, we're actually going into production for the kiosk. So it's very light assembly. It's basically that tablet I showed you, like literally, and then we have a thermal camera USB plug into it and a stand. So we wanted to make it as affordable as possible. So we're planning to go into production with that. Our app, it's a mobile-based, but everyone said they don't want another app, and they don't want their boss spying on their phone. So it's a text-based mobile solution. So that's ready to go within the next month. So we're really seeking funding to get the integration with the wearables, because that needs Bluetooth. And so we really need help on the pilot and the funding and the research side. So we'd love to meet folks who are interested in doing more prevention measures in those areas.
Beautiful. And for folks who are interested in following up with you, where can they do that?
Oh, they can follow up with me at info@volent.com and just email me there, and would be happy to reach out and talk to you.
Wonderful.
Great. All right. Well, thank you, Hazel.
Thank
Keep
you.
it up. We're going to bring Kevin Patel back. He was pulling double duty on the COVID-19 Maker Challenges. This time he's going to talk to us about the rural in-home telehealth case. Kevin, back to you.
Hi guys, it's Kevin again from HermTech. So we came back to Challenge America and did this whole thing again. We reintroduced it in the third round. We were trying to fight like the triage in the field COVID cases for nurses, so they didn't have to bring sick people in. Well, we didn't win it because Hazel won it, but we pivoted, turned it back in. We saw it'd be really good for in-home healthcare in round 4. And we quickly, I got really sad. Like, I didn't want to make cases. I thought this is simple. There's nothing cool about this. But the more I dug into the problem about how we have like 5 million rural vets and like a third of them don't have internet, and we have all these soldiers being left behind in their homes in like the telecom capital of the world, I got really kind of invested emotionally. And so what we did is there was nothing in the market. We started vacuum forming trays. So we didn't have foam, so they actually could be sanitized against pathogens in the first place. Then we put antennas in them, so that are like $20, and now they get internet. Like, we banded the whole, we don't need satellites and all this stuff. We literally just need better antennas than the small built-in ones in our iPads and iPhones. Like, we just need a $10 high gain antenna, and now everyone in rural areas has internet. And we stuck in devices for blood pressure, pulse ox, temperature, and like heart murmurs, so stethoscope, so that they don't have to come in. I don't know why we have, it's a really expensive cost for the VA to, it's over a couple $1,000 to bring them in just to take their vitals and risk their health being around other sick people and jamming up the ERs. So we tried to make it with self-administrable basic vital devices and get that internet out to them so that the VA has a foothold with that veteran, which they can then evolve in the future into other biomedical devices and tracking and forward care and preventative care, where you really get to them before a problem is, taken too large of a hold. We're looking to partner this out in Pittsburgh with Dr. Handler, and hopefully we could take this system cost that's a 20th of the cost, and the current solution is about as COTS as you can get, and works in all those places with our hospice nurses where they don't get signal for 10 miles out there. We threw them out there and they work. So we're gonna see what we can do with them.
Thanks, Kevin. Well, it sounds like you need a raise if you're asking me, but
we get paid.
Let's turn it over to our panel for some questions.
No questions?
Yeah, it's me again, Catherine. Hey, great job on this. And it's something that I think, is applicable all over, especially here in rural parts of Virginia. I'm curious, do you guys have a span that antenna, reaches? I know you said miles. Has it been tested? And what do you see for that range being the max capacity?
I don't know. We haven't found a place where it doesn't work with at least 3 or 5 megs yet. We just keep sending out to all the podunk country towns that no one's ever heard of with hospice nurses. And we track it in their cars and see if they ever lose connection. We just haven't found it yet. But, we don't have fancy testing, but
And is the concept that providers would take this out to the rural patient, or is it something that may be sent to them so they can use it independently, or what's your future vision?
No, I mean, for your geriatric or elderly, like it'd probably be a warm handoff, you know, but if you got a young veteran that's like 20 years old, dude, you can hand him an iPad, he'll be fine.
You're right.
You can just UPS it.
So Kevin, help explain what the antenna pulls from. Is it looking for cell signal? How is it accessing the network?
The same, well, we put just a more industrial router in there, and it uses just an array. Well, here, I don't want it. We kind of network bond right now, AT&T, the first responder network, and T-Mobile and Verizon. Like we do all the internets and all the LTEs, right? And then it's kind of like having a megaphone up to your ear. That's all it is. Like where you were getting a weak signal, now you can hear it clearly. It's just turning up the gain. They're like 4 decibel antennas. And we're telecom engineers from the Telecom Valley. So it gets real techie, but it works.
That's awesome. So I live in incredibly rural Vermont, and we have massive patches where there are no signals for anything. And I would love to do a little test with you.
Yeah, no, I can send one out. Is maybe if seed and contracting went a little faster, hint, like.
I have one quick question, Kevin, because we have very less time left. So do you think this will work really good with the home-based care, which is already established in VA?
Yeah, it's using the VA Connect. They're all FDA certified and integrated through it, right? But it just works better. You can't just throw an iPad out there with a weak antenna. This is the whole system. Like the VA has every individual part. They have devices, they have contracts with Verizon and telecom equipment, and now a deal with Apple and iPads. They just don't have a whole system. Like someone has to put it together.
Thank you.
Great job, Kevin.
Thank you.
Keep it up. All right, let's take it for our last of the COVID-19 Maker Challenge presenters and take it to Stephen Carr, who's going to talk to us about the Pandemi Vent 800. Stephen, welcome.
As part of the COVID-19 Maker Challenge, we created the Pandemi Vent 800. The team consists of engineers, healthcare providers, and artists from Dallas VA, Cleveland Clinic, and Hermtech. During the peak of the COVID-19 pandemic, ventilator manufacturers could not meet their demand for their proprietary sensors. Even large healthcare systems struggled to have enough ventilators on hand and have borrowed from hospitals in other states that were the least affected by the pandemic. Most agencies do not have the funds to stockpile $20,000 to $30,000 ventilators. The need to have an affordable device in reserve is imperative. With the entire world in crisis, the VET team answered the call by building a low-cost ventilator that hospitals can afford to stockpile. They worked to identify core ventilator features by reviewing similar devices in the market and worked on improvements based on end user feedback. A touchscreen that displays the vent settings was produced to resemble existing products, reducing the burden of training on end users. The supply chain failure of the in-demand sensors forced the engineers to design low-cost sensors based on available commodity hardware. An internal battery was included to allow the vent to function for a period of time without external power. The design was conceptualized and a prototype was built. With each test of the product, failures were eliminated and the end user's feedback was incorporated. The prototype was tested at the Dallas VA Biomed Lab to validate the functions we set out to include. The final design resulted in an easily transportable ventilator costing about $300, composed of readily available hardware, utilizing typical manufacturing capabilities, weighing about 15 pounds, and that can be attached to a standard hospital IV pole or ambulance cot. This solution ensures that healthcare providers will not be placed in an ethical dilemma of making life and death decisions due to the lack of ventilators. This ventilator has potential to benefit the people around the world with regards to this pandemic and other mass casualties. We ask for your support of any kind to help us with this project to take it to the next level. Thank you for this great opportunity to share our vision. And this Is it in action? How's that?
Looks good. Yeah, it's amazing. I think it's a good reminder for everybody who may not know much about Challenge America. I know Dallas spoke about it yesterday, but these are two-day events, sprint events, and the fact that something like this can be created at least in a base form in 2 days is incredible. And then obviously a lot of follow-up to go with it. So I commend you for seeing it through. Very nice job, Stephen. Let's take it over to our panel, see if they have any questions for you.
So some of you may not know, but Frank is a biomedical engineer, and I feel like Frank is best positioned to ask questions because, Stephen, this is truly remarkable, I have to say. I am curious a bit about your team. So you all were the most recent winning team. So tell us a little bit about the event, what brought you there, and how you see moving forward in this space.
This is the fourth event, I believe, that Hermtech was involved in.
Thank goodness.
So we've been working with the VA on several products. This was our choice for the pandemic challenge. Yeah, that's how we got involved in this particular event.
Amazing. You all have been busy. Indra, Catherine?
Okay. So I had a quick question. I was looking in your presentation, and tell us a little bit how the single operator is going to monitor all those multiple patients at the same time.
So each system is based on a Raspberry Pi touchscreen interface, and that has a Wi-Fi thing. We have the ability to broadcast out the data stream coming from the sensors to a centralized nurse's monitoring station that can be configured to listen to multiple devices and present scaled versions of the interface for a central nurse to look at. And they can choose any one of the smaller subsets of data to see an expanded view of any particular patient. It's a read-only interface that doesn't allow any modifications to the ventilator, but it does give you the ability to have one station and have a good clean view of each patient.
Interesting, thank you.
Thanks so much, Stephen. I'm wondering, what are you thinking as the time frame for your next steps with your group? What do you see as the next immediate goal?
Further refinements right now. We're constantly evolving it, trying to make it easier to use as well as more reliable. Again, we're new to this part of stuff. This is all new to a lot of us here, but we're trying to do it as best as we can. So yeah, the next step is to evolve it a bit more and then try and do a scaled up step for manufacturing failure mode analysis.
Great job. I think you asked some great questions, panel. You didn't need me there. Thanks, Stephen. We're going to go to the very great state of Ohio, if I may say so myself, down to the Cincinnati VA Medical Center and listen to Terry Olinger speak to us about DropEase. Terry, over to you.
Hi. Have you ever had a patient labeled as non-compliant? Well, I have, and it almost cost him his eyesight. I asked him why he wasn't using his eye drop regimen, and he simply stated he can't squeeze the bottle. I knew I had to do something at that time. Hi, I'm Terry Olinger, and I'm the nurse case manager for eye surgery at the Cincinnati VA, and this is DropEase. DropEase is a simple, easy to use eye drop delivery system designed for those with reduced or limited manual dexterity due to conditions such as ALS, rheumatoid arthritis, or generalized weakness due to aging. As an eye case manager, I've noticed there are patients that have needed frequent reorders for their eye drops because they squeeze too hard, miss their eye, and use too much product for one dose, which leads to increased costs and frequent reorders. Then there are patients who give up because they can't squeeze at all, leading to poor outcomes, impaired vision, and low self-esteem. So I went to the internet looking for a product that might work for them, and there was nothing out there that did everything. So I started making some sketches and came up with an idea that I thought might work, but nowhere to go with it. And it was at that time that I got an email from Lindsay Reigler, my local innovation specialist, requesting ideas just like mine. So I applied for and was awarded investment dollars for the Innovators Network, which led me to collaborate with the engineering students at the University of Cincinnati, who brought my design to life. Utilizing human-centered design principles, we demoed the first prototype, giving veteran volunteers the opportunity to try Drop-Ease, providing feedback through interviews and surveys. While our current prototype is patent pending, we had hoped to take it a step further and make the prototype interchangeable for all size bottles, but experienced delays due to COVID. In the future, we look forward to seeing widespread testing and feedback. Drop-Ease is a squirt gun-like dispenser that no matter how hard or weak you squeeze, it only dispenses one drop, and it will help the patient aim and stabilize the dropper, meeting all the patient's needs, improving outcomes, decreasing costs, and improving self-esteem. You just insert the eyedropper, put it to the eye, and squeeze. Drop-Ease. It's that easy. Thank you.
Great presentation, Terry. Well done. Let's take it over to our panel for any questions they have.
Great job, Terry. I feel like that last sentence was such a great commercial for this product. It's a really useful product, especially for those folks with decreased hand function. I'm curious, have you gotten feedback from occupational therapists or certified hand therapists, the people who also work with, veterans with decreased hand function, and what has their feedback been, or what has the veteran feedback been?
I have not spoken to any therapists, but that is a good idea and something I will think about in the future. But the veterans have all been extremely excited about it. They've asked if I could, all of them have asked if I could just give them my prototype to use. And I'm just like, I've only got one, so I can't give it to you. I've even had staff members who have parents who do eye drops and other staff members who actually use eye drops themselves, ask them when it's going to be out.
So Terry, I have to say, great pitch. You have learned well. You've been well supported by Lindsay and the Innovators Network as a whole. So tell everybody a little bit about your experience with Spark Investments and what's going to happen for Drop-Ease in the year to come.
Well, in the year to come, we are working to contract with an industrial design engineer so that we can manufacture a couple of these that hopefully will be able to support several different size bottles. And then we can take those and do a small scale testing again that would make it a manufacturable product, and hopefully do another test with that and have our finalized prototype. So I'm very excited about that.
I have a question, Terry. You are so perfect in the pitch. I think so in 1 or 2 years, you are ready for the Shark Tank. It was a pitch which can be like bid by several sharks. So it was amazing the way you presented. So a quick question that how much cost you are thinking of, like of one piece?
When I spoke to the students and we talked about it, right now, because this was a 3D model or printed from a 3D printer, and when it was printed, it retailed or cost them about less than $8. But again, that was a printed version of it. I'm hoping that we should be able to make it for less than $10 each. But I haven't, again, talked to an industrial engineer to actually give me specs on the cost, because it's just two pieces actually it would just be two pieces of plastic that come together with screws. And it's just a little rack and pinion piece in here that just moves the lever, that just simply squeezes the bottle, just like a squirt gun. It's not a lot of pieces on the inside.
Thank you.
Mm-hmm.
Great. Well, thanks a lot, Terry. Future's bright for that one for sure.
Thank you.
Thanks. All right, we're going to stay in Cincinnati with Miser Gooley at the Cincinnati VA Medical Center, and he's going to present Mobile Simulation Cart. Miser, over to you.
Thank you so much. I appreciate that. On July 19th, a patient in the Cincinnati VA Emergency Department didn't receive a procedure he needed to receive. The reason for this was there was no provider at the time who was comfortable to perform this procedure. Unfortunately, this same scenario has been playing out in VAs and medical facilities all throughout the United States. One study found that up to 39% of graduating physicians indicated a lack of comfort with performing certain bedside procedures unsupervised. As an educator, I believe not in practice until you don't make a mistake. Rather, I believe in practice until you never make a mistake. The VA endorses the same mentality and has spent over $50 million nationally on training devices designed to help perfect clinical skills, chief among them procedural skills. So how is it possible that we spent so much money but still have a major issue in delivering proper patient care? The answer is simple: space and labor. These devices are underutilized because we take them and we store them behind locked doors in some far-off non-clinical storage space. Then, when they're finally requested, the labor required to set them up and break them down is prohibitively too high oftentimes. Introducing the Mobile Simulation Cart. This self-contained mobile practice station this device will allow these practice devices to be brought to the clinician, or better yet, co-located with them wherever they happen to be. And because it has both a training and a storage position, it requires no additional space to perform the training required to become a better practitioner. Applicable to all fields of medicine and nursing, this cart can be armed with the practice devices targeting the selected employee. In our early product testing phase, we sent this mock prototype to VA experts across the country, and they universally agreed that the final version of this product would be highly used, increase staff productivity, and increase the clinical volume of training occurring within their facilities. This upcoming year, we're working diligently with a local designing firm to bring the full-sized version of this to life. Please stand by as we make this model of a cart become the model of better procedural training within the VA system. Thank you so much. And since I have 45 extra seconds, I want to thank the Innovation Network and specifically Lindsay Riegler, because this and everything that's come from this wouldn't have been possible without her or the network themselves. So thank you for that. And 30 seconds to spare, I will relinquish my time.
Thanks, Miser. Great job. I think this is a great example of the, start small, fail small mantra that the Innovators Network has. I mean, we were talking, last year, it's like, we were discussing this and the idea that you have to build something out full size is, that's ideal, but you figured out a way to scale it down, and man, you can ship that thing, to people to get their feedback. So, you really nailed it, I think, when it comes to a Spark device related project. So great job. Let's take it over to our panel for some questions.
Yeah, I couldn't agree more with what Frank has said, Miser. The way that you have developed your prototype and really truly integrated feedback into your design is remarkable. I'm curious a bit about what are the components of the cart and what types of procedures could a clinician potentially be trained on?
Yeah, so that's an excellent question. So the first part is, what are the parts of the cart? So there's essentially a shelf unit, the procedure that goes on it, and then it goes into these different positions so that you can go into an active position. So this would be the active position to then perform this procedure. Now, in healthcare, there's all these different professions. There's medicine, there's surgery, there's nursing, there's occupational therapy, there's all the various therapies that exist. And each one of them has competencies that they have to show and prove. So for instance, one of the main uses that we think that we'll be able to use this for in the first year is we'll be able to set this up with various women's health procedural equipment. So like the breast exam and the pelvic exam. And we can go ahead and take this cart and roll this and take a provider who doesn't feel confident in women's health and actually bring the things that would be necessary for them to become skilled in those procedures, so that by the time that we're done and we walk away from a session, they'll be armed to take better care of their veterans. So it really is any procedure. So nursing has competencies, and the fact that we could bring this cart to a third shift employee instead of the third shift employee having to truck their way to wherever the devices exist to show their competencies during orientation and training, I think it goes so far as to not only create a better experience for the veteran and the employee, but it actually goes so far as to show the employee that we care about them, that we're willing to accommodate them and bring the devices that we oftentimes expect them to come to. We'll bring it to their lap and we can leave it with them. So it really is the wide gamut of nursing, physicians, and all the various associated health providers that we rely on every day.
I love it. It really underscores the fact that access to needed materials or to, whatever it is that we're discussing isn't just for patients. It's very, very critical that our staff have access to what they need. So is it appropriate to say that it's kind of like the Bowflex of clinical training devices because it looks like it can kind of do it all?
Yeah, think of it like the Bowflex, but without the cable. So you bring the cables, we'll bring the Bowflex machine. That's exactly the way to think about it. So yeah, we're really excited. And I think that the whole thing came to be because the VA has really good intentions about making sure that good healthcare gets delivered, but we're limited based on labor and we're limited based on space. And so the idea to solve those problems was really the heart of this design.
Wonderful. Thank you.
Great.
Thank you guys so much.
Great job. All right, we're going to keep it in the Buckeye State. I sense a theme here, and go to the Chillicothe VA Medical Center and have Beth Able speak to us about aromatherapy to decrease the burden of PRN medications. Beth?
Hi, thanks, Frank. So most people over the age of 65 are actually on multiple medications. Many times more medications are prescribed to treat side effects of the first medications. When first starting the aromatherapy program at the Chillicothe VA, veterans on the community living centers were on an average of 15 to 20 medications with multiple PRN medications prescribed. PRN medications are also known as needed medications. I personally had a lengthy background with aromatherapy and its effects, so we decided to implement it in long-term care. Aromatherapy is a non-pharmacological approach to promote overall health and well-being. The initial pilot took place in 2018. As a result of the pilot, we soon realized using aromatherapy to its full potential can support the body's innate healing mechanisms, as well as offer relief for pain, anxiety, sleep, appetite issues, and relaxation. It can also lead to a reduction in the use of as-needed medications. For example, when a veteran has difficulty sleeping, instead of going straight to that sleeping medication like trazodone, we would start them on aromatherapy that gave them a calming effect and helped them fall asleep. We did see a few scheduled medications decrease over the pilot. However, the majority of decreases that we noticed were among the as-needed medications. Recently, I received an email from a physician. She is now offering aromatherapy to her patients. She told me an elderly veteran who had been on Ativan for anxiety at bedtime stopped taking his PRN as-needed Ativan. He had been on Ativan many years and told her he didn't think he needed it anymore. He also said he liked that the aromatherapy didn't give him any side effects. Two barriers that presented themselves earlier with implementation was the cost of certification, as well as the consistency of education programs. Many of the external programs focused on personal use and did not have enough information. These programs were costing us $1,500 to $2,000 per person to get our people certified in aromatherapy so that they could offer it to the veterans. So I took it on myself to create a aromatherapy program and packaged it up and sent it off to National Association for Holistic Aromatherapy. This program was accredited in January, and since that time, I've worked with National EES to get continuing education hours assigned for nurses, doctors, psychologists, pharmacists, and more. Since receiving the accreditation, we've been able to teach certification courses to over 70 staff at 10 different VA medical centers across 6 VISNs. Many staff have reported that they love the class, learned so much, and are so excited to use it with their veterans. This program not only enabled Chillicothe to spread it throughout all of their areas, all of their care lines, but we've also enabled other VAs to implement a robust aromatherapy program in places like long-term care, whole health clinics, pain clinics, and even a drive-through where veterans can come in to get their aromatherapy. Over 100 veterans across this quarter had aromatherapy initiated. I frequently get calls from other facilities wanting to bring the aromatherapy program to their veterans. A physician I recently had an email from told me about and I think time's up.
Yeah, thanks. Thanks, Beth. Maybe we can take some time to answer some questions here if you can get to that last point. Turn it over to our panelists. Any questions?
Yes, I'm sorry.
Yeah.
I was muted. Sorry about that. Thank you, Beth. Because you are so big and expert in the aromatherapy, give us a little bit insight beside the application in the older patient. What about the other services like mental health or somewhere where you have like a, not the older patient, how you can see the aromatherapy in those services? And other question is that, is it integrated with the whole health system at this time in the hospital?
Okay, so first question. I actually recently had a psychologist who is certified in aromatherapy reach out to me. She had been making it for some of her younger veterans that have PTSD and difficulty sleeping. One of her patients said that he was able to wean off of his PRNs for sleep and rely only on his aromatherapy. He's been very happy and excited about the aromatherapy and has requested to try it for other needs that he has. She has also used it in decreasing smoking with veterans in the younger population as well. And she's been making them inhalers. And when they utilize the inhalers, they've actually been reporting back to her that they've had a reduction in the amount of cravings that they've had. So there's a couple cases right there from mental health from one of our acute mental health psychologists. She also works with the PRRTP program, the inpatient mental health program, or long stay, I'm sorry. And some of those smoking cessation ones were from that group as well. So it started in geriatrics, but it's spread throughout all different ages. As far as whole health, we actually have integrated it in different whole health programs at different VAs. And it does count as a whole health contact. So it does count towards those contacts to increase VERA reimbursement. I've actually given sites guidance on how to build their clinics to appropriately capture, as well as have spoke to some national Envision whole health calls and have put some different guidance out on the national whole health page that's got a toolkit for aromatherapy.
Thank you, Beth.
Thank you, and Jeff.
Yeah, this is a great program, Beth. Curious, are people using it at your facility for both inpatients and outpatients? And is there one aroma that people just really prefer?
There really isn't as far as one aroma that they prefer, but in Chillicothe, they are using it for inpatient and outpatient. That started in the CLCs, but then it really took off in home-based primary care. And after implementation, within just a couple of months, over 50% of those veterans were utilizing it in home-based primary care. We're also seeing it utilized out of the pain clinic in Chillicothe. And then there's a couple of other facilities that are implementing it in outpatient settings as well. So there has been some of the struggles that we have and some of the need going forward is trying to figure out, how to easily refill these things. People get their aromatherapy and they want more. So currently they just come back to the people that issued it to them. They'll add a comment to the original consult, because everybody that is issuing it is an aromatherapist. They are certified in clinical aromatherapy. And so they'll add a note to the consult that the person stopped back in and they reissued it to them.
Thanks so much.
No problem.
I had so much that I wanted to ask you about the drive-through aromatherapy, because that is new, but we are out of time.
Brand new.
Yeah. So anybody else who's interested, get in touch with Beth in the demos tab. That's awesome, Beth.
Thank you.
Thanks, Beth.
Thanks, Frank.
All right, moving right along here. We have one more from Chillicothe VA Medical Center, Matt Cox, who's going to talk to us about the ever popular bike share program. Matt?
All right, thank you. Bike share program saw great success for fiscal year 20, to include winning the Tanked Award for the best innovation brought back to life from one that had failed. But we continue to have our problem today. How do we encourage and increase veteran, employee, and community activity as well as mental stability? Veterans that live or come to visit our facility have nothing to do activity-wise, except for going to our gym, which the gym is only open certain hours if it's even open, because it's closed right now due to COVID. Our employees continue to sit inside their office or don't want to go out, so they call a shuttle to take them from building to building. So how do we help? Our idea of supplying bicycles was extremely helpful this year for fiscal year 20. But what about the bad weather days? What about the pandemic when we can't go outside? Smart trainers would allow a veteran or an employee to stay inside and ride a bicycle that we would connect to a stationary that is then linked to a laptop. This stationary would allow a rider to ride through scenic areas such as mountains, deserts, or even roads that you know that is connected to Google Maps. You can compete against one another if you have multiple stationaries. And this also allows us, the bike share, to keep track of their stats and the activity that is used on the bikes. The only requirement is for a Wi-Fi signal and Bluetooth so that the stationary can hook up to the laptop. As a Spark recipient for fiscal year 20, we were able to put disabled veterans onto bicycles. We were able to get employees and veterans another mode of transportation on our campus, and we added exercise to their lives. With a seed for fiscal year 21, we would be able to keep the program going year-round and through the weather and not just in the summer. This also allows veterans and our employees who are afraid to ride outside and have people see them the ability to ride indoors so that others do not have to see them riding. At this time, we do have one employee that is testing out this equipment, and we tested him for 30 days. Day one, he was able to ride for 3 minutes nonstop, or 3 miles for nonstop. Now, day 30, he was able to do 15 miles nonstop before he had to stop. This shows that this program is working. Thank you.
Great job, Matt. Like I said, I know it's a popular program, and you've come a long way with it.
Yeah.
Let's turn it over to our panel for some questions.
Matt, I gotta say, I love this project. The way that you re-envisioned the previous resources that were given to Chillicothe was really beautiful last year. I'm wondering if you can speak a bit about the sort of nuances of your campus itself and how environment really plays into sort of driving innovative ways of looking at things.
Yeah, so we are a very rural area. We have, the buildings are spread out a lot. We have wide open space. It has a golf course, and a lot of the programs that we have here at the VA, they have to walk clear to the other side of campus, which might be a half mile to a mile in distance. We have the ability as well. We have shuttles, but it's hard to get a hold of one shuttle or different things. So with us being able to supply the bicycles, and now we are a no smoke facility, we have taken over the smoke shacks as well. And we have now what we call them bike shacks. So we are slowly moving around the campus to allow the veterans, the community members to come in. Our community is very well into this program. We've been donated a lot of bikes, and they have got with me. We've been able to create a program that takes veterans out into the community to different memorial highways as well. We have 4 memorial highways in Chillicothe, and last year it brought over 200 riders to our campus, and we were able to take the community out to those areas. Just today, it's pouring down rain here, and I had 3 veterans come for bikes because this weekend they want to ride. Even with the cold weather, they want to keep this program going.
It's awesome to hear you're so passionate about this, Matt. I'm wondering, with other people being so interested and invested, does it ever get competitive with who's ridden more miles or the stats?
We had a big group last year. Last year we were able to do guided bike rides every Wednesday. This year we were not because of COVID, but we had 2 or 3 guys that and a woman that was racing against each other every Wednesday to see. We used an app called Strava, and they would compete to see who could get the most mileage in a week. And honestly, it was amazing to see 3 inpatients average over 100 miles a week. And it just shows that these guys and gals love it. I mean, they're all about it. And we actually have one veteran, we're waiting on a hand cycle to come, that is dedicating himself to taking that next year to the wheelchair games.
Awesome. Thank you.
Great. We're about out of time, but thanks again, Matt. Great job. All right, moving right along here. Next, we have Alyssa Welch from the Central Arkansas Veterans Healthcare System. She's going to be talking to us about the engagement solutions in the Community Living Center. Alyssa, welcome.
Hi. I can't see myself, but hopefully you can hear me. There we go. It was on and someone turned it off. Host stopped it.
There's usually you're the one. I was going to say, Alyssa, usually you are the one causing the trouble, so this is apt.
I am. It says I cannot start my video because the host has stopped it.
Well, my goodness. Do we have Caitlin here? Would you guys mind switching while we sort Alyssa out? Would that be okay?
Yeah. Should we?
All right.
Yay.
All right. Yeah. Woo. I am kind of a troublemaker. Sorry about that. It's who I am, you know. So some of you guys, should I go ahead and get started, I guess, since I'm back on? Okay. All right. Okay. Sorry about all the trouble. I'm kind of known as a troublemaker. I've been around the block a few times with INET, so I'm very pleased to be here again this year. My name's Alyssa, and I'm coming to you from way down south in Arkansas. 2 years ago, I came to INET with a Spark investment request. And so my idea was to make patient engagement to be more than just talking about, have you had your medicine, or have you pooped for the day, or, you know, just all those medical questions. And so we kind of, as a recreational therapist, I wanted to think about how can we get our bedbound veterans involved in things outside of their room, even if they're stuck in their room because of wounds or whatever. So we took how might we get bedbound veterans to bingo? How might we take them to a concert? Or actually this Sunday, we're going to be having Dad's Old Car Show outside. So how can we bring that inside to them, even though they couldn't leave? So we said, what if they could do all the same things that the other veterans were doing on campus? So after working on that for about 2 years now, we have a solution. We have Rec TV, and it's engagement solutions in the Community Living Center. And we use multimedia to include our veterans in activities that they were missing out on before. We provide upcoming events and activity schedules, but we do live broadcasts. So we bring the outside to them. We do special curated content. We do vintage TV shows, music specials. And yes, we play bingo in our Community Living Center, which is a big favorite for everyone. So community has never been more important now that we're in social isolation with the new norm of no groups or limited group activities. So we're leveraging Rec TV to fill the gap during this unprecedented time by having partnering with social work, health and wellness, and psychology to participate in yoga, Tai Chi, health and wellness workbook sessions, scheduled relaxation and guided imagery. So all this is available to our veterans at the click of a remote control. So we just want to say thank you for all the support that INET has given to Engagement Solutions over the past 2 years. That's helped us bring it up to the level that it is. And I'm confident that we're going to continue to grow. We're going to continue to move forward. And if anyone's interested in bringing RecTV or innovation solutions to their VA, give me a call and I'd love to help you out with it.
Great. Thanks, Alyssa. Great presentation. All right, ladies, over to you for some questions.
So I have always been curious, Alyssa. I know that engage it's all right. There's a very public audience here, I promise. I've always wondered, what is the one, you have lots of different options in this RecTV engagement solutions. What is the most popular? And how do you choose when to add content, and how do you choose when to drop content?
So I try to continually get feedback from our veterans. And because I'm one of the recreational therapists in our CLC, I see them a lot. So, I just periodically go through. We have done some official questionnaire survey type things, but usually I find it's a lot better just to talk with my guys and a few gals and just ask them. So Westerns are our absolute most popular thing that we show on RecTV. And because of that, we have all day Saturday is just Western movies back to back to back. We had a guy that when I asked him, his favorite thing to say was, I could never put too much John Wayne on there. So, but then after that, I would say live bingo is probably number 2.
Hello, Lisa. So do you sometimes also ask veterans that, do you have any choice, like to watch any specific movies and then you put it all those, or is it very specific on the RecTV?
So sure. So we've had some of our veterans who will ask if we can show specific movies. And if I can't find the exact title, I try to at least get in the same genre. But a lot of times it'll be a little more vague. We have some veterans who really enjoy sci-fi. So I try to find sci-fi movies to play. We do like a Friday night special. And then on certain other nights of the week, we might feature, we have a music night. So once a week, I put different types of live performances on that the veterans have requested. So I try to really keep it veteran centric and see what the guys want to watch and what they want to have on there. So.
Hey, Alyssa, one other question. On the back end, like, how do you provide the content? Do you drop and plug it in and then it's available? Is there a contract that's required? Where does it pull from?
So I have a contract with a content managing company. And so that's who supports all the movies, all the flyers. So it's kind of like having a calendar perpetually moving with the exception of when there's a program playing. So if we're doing live bingo, the flyers aren't going around. But so I upload the content that I want and schedule it when I want it to play. And then the company, we pay them obviously a fee to just manage all of that and to keep it running and to plug all that stuff in when it's supposed to show. So, but it's really a minimal expense if you think about it. Anything else?
Great. I think that's going to have to wrap it up. But great presentation.
Thanks so much.
Great work down there in Arkansas. All right. Next, we have Caitlin Rowlands from the Charles George VA Medical Center. And talk to us about virtual reality immersion.
Great job.
Therapy for veterans.
Thank you.
Okay, I'm trying. Hi, we can actually. Hey, Alyssa, you're still causing trouble. Can you go on mute?
All right, here I am. Hi, I'm Caitlin. While I began my career as a floor nurse on our post-surgical ward, my role is now primarily focused on managing and expanding the project I started in 2017, Virtual Reality Immersion Distraction Therapy for Veterans. The story began with a desire to decrease post-operative complications, improve pain management, decrease opioid use, and improve the overall experience of veterans on our post-surgical ward. As a new RN, I remember giving patients multiple doses of IV and oral pain medication each shift, minimal non-pharmacological interventions available, and thinking there has to be a better way than this. With an interest in integrative therapies and a background in art and graphic design, it's really no wonder that my aha solution was virtual reality. Our virtual reality software uses clinician-developed imagery and sounds to create a truly immersive experience, enabling veterans to be distracted from their pain, stress, anxiety, and boredom without being triggering to such diagnoses as PTSD. Through environments such as interactive games, meditative natural spaces, virtual painting, and art museums, veterans may now be transported out of their hospital bed, out of the chemotherapy infusion clinic, even out of their wheelchair to a world where those negative stressors do not exist. I can tell you from experience that watching a typically agitated and restless wheelchair-bound veteran laugh and smile while exploring the woods in VR will make your day. 100% of veterans using VR to aid with restless behaviors had a decrease following a session. I can also tell you that helping a veteran who just had his second amputation finally get some relief from his pain by launching virtual snowballs at targets will make you want to reach even more veterans like him. 63% of veterans stated a reduction in pain score of 1 or more points. I can also tell you that standing by while an 89-year-old patient about to go have a painful procedure tells you all about his favorite music while he views paintings in our virtual museum will pull at your heartstrings and make you a little teary-eyed. 96% experienced a decrease in their stress and anxiety level following a VR session. Despite the pandemic, at Charles George, we have completed over 100 sessions this year, almost 200 in total since this project began, and over 50 VA employees have been trained at our site and others. Though this project started on only one inpatient ward, virtual reality is now being used throughout all inpatient areas, our community living center and hospice, oncology infusion clinic, day surgery, and post-anesthesia care unit. We've also utilized VR with employees to give some relief during stressful shifts, and soon we'll be using VR during outpatient procedures and in our outpatient pain management clinic. Thanks to INET spread funding this past year, I was also able to expand this project to 4 other VAs. Struggled due to the pandemic, but we're pushing through. But VR has really now taken off within the VHA with various new indications for use popping up all over the country. With the right funding and continued stakeholder support, the only limit to what we can do with it would be our own imagination. Thanks.
Great job, Caitlin. 96%, that's impressive. The future is certainly here. Let's take it over to our panel.
Great job, Caitlin. Those were really beautiful and meaningful examples of the veteran experience you were able to provide. Does the VR set have a repository of options, or how do veterans choose which one they want to experience?
It really depends on the VR software that you're using and hardware for that matter. So I've used different types over the course of this project in general. The ones that we use right now, these are from a VR company local to where I am, and it has about 10 different options in it that they get to choose from, different environment options. Depending on what kind of setup you go for, it can be anywhere from 10, built from the ground up, all the way up to hundreds that you're downloading onto an individual headset. And the quality changes depending on what kind of thing you're using. The hardware changes, but that's something that we're working out within the VHA, creating a VR, XR kind of network in order to handle these sort of things. But right now, I have one that has 10, and then I have another one that has 24. So it really just varies.
Yeah. Is there any one experience veterans seem to prefer the most?
That also varies. It depends on the indication for use. So say if it's for acute pain, it may be that shooting snowballs at targets is the best thing because it's the most interactive. It's the most, acutely distracting thing that they could be doing. If they're really stressed and anxious about an upcoming procedure or something they just found out about, it may be one of those meditative natural spaces where they're hanging out by a campfire and listening to birds and water. And that may be what they need in that moment. So it really just varies. One of the cool things is that we also have areas around here depicted in virtual reality. So a lot of our veterans who used to be able to go see those natural spaces and can no longer get there, get to actually experience them again in virtual reality, like the tops of the mountains around here, which is really cool to watch.
So Caitlin, at one point, I'm sorry to interrupt. At one point, you mentioned that it was like clinician developed VR experiences. Can you share with us the partnership? Are the VA clinicians actually helping to develop the content?
Well, it's mostly me helping, but then we're also in kind of a partnership with a local VR company that is owned and ran by clinicians. So an anesthesiologist, ER doctor, and osteopathic. So, I mean, they have a whole team of physicians and clinicians that develop all of this software with, the patients in mind. And what was really cool is that from the very beginning, they were creating software specific to our veteran population because they wanted to help veterans. And so they've been great at customizing things for me over the course of the past 3 years for that purpose.
I only want to add one thing, Caitlin, that we did implement this year and it's coming out good. Because of the COVID, it's a little bit delayed, but you are on it and it was very good success. Congratulations for that.
Wonderful.
Great job, Caitlin. I don't know what's more expansive, the library selection of VR or the jarred spices in your tiered cabinet rack back there.
I know, it's all of my herbs and things. I make lots of fun stuff.
I'm jealous. All right, thanks a lot.
Thank you.
And last but certainly not least, we have Carolyn Gartner from the Martinsburg VA Medical Center, and she's going to present Operation Peace. Carolyn, welcome.
Hi, I can't see the timer. There we go. Or me. Am I on?
You
there.
Are.
Okay. Meet Sue, U.S. Army veteran, mother, victim of domestic abuse, chronic pain, homeless. In December 2019, she found Operation Peace at Martinsburg VA. Twice monthly in-person group Reiki sessions. Reiki is a bioenergetic practice that restores balance to the body and induces deep relaxation. It's practiced hands-on or at a distance. Everyone can learn to practice Reiki. Like 90% of attendees, Sue felt calmer and her mood improved. She soon secured a home. Then COVID-19 hit. All VA group classes canceled. The fear and isolation rushed back in. Until Operation Peace shifted to 100% virtual, she could attend safely from her home. In her words, "This has been life-changing. I'm a better mother. I'm able to manage my pain. I have a plan of action if crisis strikes again." I'm Carolyn Gardner, physician assistant and lead of Operation Peace. Operation Peace expanded access to the whole health practice of Reiki with additional monthly group sessions and virtual access to all Reiki offerings. In March, COVID-19 forced a pivot to 100% virtual Reiki. First quarter data, 100% in person, showed 90% were calmer with improved mood. 100% virtual third quarter data showed 99% felt calmer and improved mood. Customer satisfaction was 94% above average to very high. No one felt no change. Veterans report no preference for in-person versus virtual. An employee branch was added to support Disaster Emergency Medical Personnel System, or DEMPS volunteers. RN John worked long, grueling hours as the pandemic continued. He was exhausted and scared. With Operation Peace for DEMPS, he felt calmer and managed stress better, like 69% of participants. The first 100% virtual level 1 Reiki training for veterans showed 80% felt more empowered to manage PTSD, depression, and stress, and 60% felt more connected. Customer satisfaction rate was 100% excellent. As a PA for 35 years, I've never witnessed such consistent response in patients. In these unprecedented times, this project expands safe virtual access to tools for stress and pain management and self-empowerment. Operation Peace can be easily expanded with minimal capital investment to empower even more veterans to say, as Sue does, "I return to my family a better version of myself. Thank you for offering this to United States veterans. This has changed my life."
Great. Thanks a lot, Carolyn. Great presentation. Very thorough. Let's turn it over to our panel for any last questions.
Carolyn, it sounds like this program has so much great data to really support this initiative. I'm wondering, do you ever have veterans who are skeptical, and what do you say to them to put them at ease?
Actually, I have had a lot of veterans who are skeptical, and it's been, I have to say, it's been relatively a surprise to me that everyone that I've offered this to has responded positively. I just say, you know, it can't hurt you, and let's give it a try and see how you feel. So I invite them to push their ego to the side and not try to figure it out, because that gets into the way of the flow. And it is astonishing. I have 80-year-old patients. I have a variety of people from in the 40s through much older ages, and very, very interesting.
Carolyn, great story. Thank you so much for sharing it with us. Thanks. And for the work that you've done with virtual Reiki. And I have to say, I was one of the skeptics, y'all. I was like, there's no way this works virtually. And Carolyn did exactly that. She said, let's set up a demo session. We'll try it and we'll see what happens. And it was remarkable. So Carolyn, we have a little bit of time. I'm wondering if you have a way to try to explain to the audience how you can tap into Reiki energy over a virtual medium. How does that work?
So everything is energy, and it is not stopped by time or distance or solid or liquid. So I can connect to you just thinking about connecting. And that's really what happens. It has to do with the power of our intention and the power of our thoughts, which now quantum physics is showing absolute scientific data to support change of, you know, physical content with our thoughts and our intention. And then the Reiki energy just flows from the practitioner to the recipients.
I'm with Brian. I never thought that it can work virtual. And I was figuring it out, that question I have to ask you. And that's like, so I always have in mind that you have to be close and your hands should be like at some distance. So that's very amazing.
Yeah, well, it's actually stronger. It's actually stronger distantly, but I wasn't sure it would work for people who had never had it hands-on, but had to give it a try. And people say they have no preference, which is incredible.
Wow.
So Carolyn, what's next for your program?
Well, we have a spread for next year. We're spreading to 2 other VAs and to employees in Martinsburg, and everyone's so excited about it. My team's now expanded because this year was pretty much me. And, and I have a lot of people now. It's very exciting.